Allied Health Professionals, also abbreviated as NMAHPs. My name is Anina Schmid, and I'm a specialist musculoskeletal physiotherapist and an associate professor in clinical neurosciences at Oxford University. I'm chairing this webinar today on behalf of our project team of the Next Generation Leadership course, which is organized by the Oxford Biomedical Research Centre. Our group includes Dr. Dimitris Koutoukidis, Dr. Fiona Bragg, Dr. Michelle Gunasakera, Dr. Jennifer Carter, who will speak to you later in the webinar, and we are very honored to be mentored by Terry Cordray. This webinar will be recorded for those of you who cannot attend in person, so I therefore ask you to please keep your microphone muted and videos turned off during the talks. The program for today is as follows. First, Dr. Helen Woltholm will present on the importance of research for clinical practice from a nurse and midwife perspective. And this will be followed by Terry Cordray with a focus on allied health professionals. We will then hear from Jo Snowball, and she will give you the perspective of a junior clinical academic. And then Karen Barker, who has an amazing wealth of experience in this area and gives you the expertise of a senior clinical academic. And in the end, Jennifer Carter from our team will introduce you to the new OXRAIN program, which is an exciting new program for NMAHPs to take a very first step into research. At the end of the webinar, there will be time for questions, but if you have any during the webinar, it is best if you enter those in the chat function. Now, it is my pleasure to introduce Dr. Helen Woltholm. Helen is the Director of Nursing and Midwifery Research at OUH and the Education and Training Lead for NMAHPs at the Oxford BRC. Helen is also a cardiac nurse by background and has worked in senior clinical positions within the academic sector, leading curriculum development both in advanced practice and research. She is also an active clinical researcher in the field of cardiovascular care. Thank you very much for speaking to us today, Helen. If you don't mind, just unmuting yourself and then take over from me.
Thanks ever so much, Anina. Is it okay? Can you all see the slide? Okay.
Yes, that's perfect. We can see and hear you. Yeah.
Lovely, thank you. So thank you for that introduction. So I'm not going to waste time because we've only got a short period of time. So I'm going to move on to my next slide, really, which is what I've been asked to illustrate with you today. So firstly, from a clinical research point of view, from a nursing and midwifery point of view, what we need to really think through is the care we deliver and how research can inform that care, both from a patient's perspective and from an evidence-based point of view. And when we look at how evidence informs practice, we need to really think through what we're doing, why we're doing it, how we involve patients and carers within that, as well as members of their healthcare team. What we need to really think through from a clinical research point of view is that we do not dictate what research needs to be done for patients, but we need to involve patients within that so that they are aware of the evidence base that is put forward for them, so they can make a choice in what is the right care for them to receive and to have a active voice in the decision of their care. What is also quite important from a clinical research point of view is, as clinicians, we do not dictate what the research should be. The research problem should emerge in partnership with our patients and their informal carers, as well as us as clinicians working with them together. So patient choice and patient's perspective of research priorities needs to take a lead within how we develop clinical research. From a research point of view, what is also really key is staff development, and within the OUH we haven't really grasped this as much as AHP colleagues within nursing and midwifery, and we need to really look at how we can develop staff along the research pathway to ensure that we're enabling best care, we're enabling evidence-based practice, but we're also enabling staff development within that. That is absolutely key for both recruitment and retention. From a pre-reg point of view, that students on qualifications see that this is a good place to work, that we take seriously research within practice, that we look at how we are developing our staff to maintain staff. So it's not only as we're recruiting staff, but also that we retain valued members of staff within that clinical environment. And key to that is that people see that there is a very clear career pathway for them. So from a nursing point of view and midwife point of view, what we need to think through, that pathway can be twofold. It could be within research delivery, or it could be along the academic clinical career pathway. So we're working quite extensively on how we can explore career opportunities both within a research delivery, so as a research nurse working within delivering research studies, but also as a nurse or midwife who wants to develop along a research pathway and be a leader within research in their own right. And Ina's just asked me to illustrate one very small incident of how research can transform care. And the example I'm going to give is from a heart failure perspective. So we identified with patients, their carers and clinicians that patients found it very difficult to communicate where they felt from a breathlessness point of view. Heart failure's two main key symptoms are breathlessness and fatigue, but patients felt we were talking clinical language, not their language. And so we explored what they felt about that, why they felt that was a problem. And as an example, they would be asked to label their breathlessness on a Borg scale, which is a number 1 through to 4, and they didn't even understand what 1, 2, 3 or 4 meant. It wasn't their language, it was our language. And so from that initial meeting and issue that was identified by both clinicians and patients, we have developed a patient-reported outcome measure, which is a tool for breathlessness and fatigue in heart failure that has emerged from patient voice. So all the descriptors of how patients perceive their breathlessness are from patients' words. And we've developed that, we've validated that, and we're now about to start a feasibility study about bringing that into practice. And so that is just one example of how a clinical problem can be transformed into a research project and then put back within practice to move practice forward. And I'll now hand over to Terry. Thank you.
That is wonderful. Thank you so much, Helen. And that is an excellent example. Really, you kind of take a question from clinics and you start to make direct impacts in clinics. So that's fantastic. Thank you. I'll introduce you to Terry now, and it's an absolute delight that you're talking to us and are mentoring our project, Terry. Terry Caudry is a physiotherapist who specializes in older adults acute care and rehabilitation. He's employed by OUH NHS Foundation Trust as a Trust Head of Therapies. Terry is also a PhD student at Oxford Brookes University and investigates the use of physical activity interventions on the outcomes of hospitalized older adults. Terry, we are very curious to hear your perspective on how research is important to integrate into clinical practice.
Oh, thank you very much, and thanks for inviting me. And that's a great talk by Helen. I saw Helen's slide, so I'm not going to duplicate that because there are quite a lot of similarities in why research is important for nursing midwives and AHP. So sort of slightly different spin from me, but I'm keen to talk about sort of AHP clinical research and perhaps a perception of research being quite a big entity and an overwhelming mission, when actually I think sometimes the answer is right in front of us. So I've taken a caption from the Imperial College Healthcare NHS Trust research strategy, which I think is a really nice spectrum from being research aware to research active. And I think often the starting point really for our professions, even if we don't choose to undertake research, then we certainly work to embed research in our practice. And I think that definitely should be the starting point. I have to say that I'm sort of coming from this presentation with a manager's perspective, because I know, or I certainly feel, that research in clinical practice can be a leadership issue. So something I've written here is that people cannot be what they cannot see. The important positive research culture role modeling. People who are undertaking research need to be seen in clinical practice. They need to paint a picture and a vision of what it can be like to do research for the many staff that have that aspiration but don't quite know how to go about it. I think the best teams that I've worked in are those that are often curious about problem solving and embark on growth and development and trying to solve those clinical issues that are so important to patients. So where there are clinical uncertainties or gaps in knowledge, teams that sort of work to solve those issues are often the best at working, in my view. I have lots of experience of people trying to do research that's not funded, and I think, you know, unfunded research doesn't really get started, and it certainly doesn't get finished. So if you're a manager or a leader, you know, really think about what you can do to support applications to fund a timeout, fund training programs to improve people's capability, agree to secondments, perhaps, if you can manage that, and reflecting on a point that Helen made, developing clinical academic posts is absolutely critical. We don't need everybody to be doing research, but, you know, in the service that we run, we've got about 25 teams, and it would be good if within each team we had a small amount of time out for people doing research. I think that would make a massive difference. I think something that's really helped me is making connections. Oxford is a research-rich environment. It does create an expectation that sometimes is difficult to meet, but it does mean there are lots and lots of people and organisations willing to help and talk to you about their experiences. And so I would definitely advocate for that. And going back to that point of being curious, there is so much that is in front of us every day that I think can inspire research projects. And Helen raised an example around heart failure. This is a personal example to me. A while back, I was asked just to get involved with a trust-wide falls strategy. And first sight of the data, the overwhelming number of people that fall in hospital and experience various degrees of harm is overwhelming. It's into the sort of around about 700 people that fall and are found on the floor, and we don't understand why they've fallen over because it's unwitnessed. So that sort of leads me to think, well, how, you know, why is this happening? Why has this puzzle come about? I then sort of had a chat with a few people who are slightly more informed around falls management. And I guess we raise a question, what is it that we can do about it, or has the problem been addressed already? So that would lead you to sort of go into healthcare databases and searching for answers that may be out there already. And if they're not, I think that's the point where we say, well, how can we get this project funded? Because it's important. You know, if we can stop people falling over and we can prevent harm, that's a good thing, and that is an investment that surely people would be willing to make. Often I find in my experience as a manager is that people are quite curious, but they don't even get this far because it's too difficult. So I think we need to be a bit more open to facilitating and helping people's curiosity to solve clinical problems. And I'm currently a PhD student. It's a great experience. The learning and discovery and the thought that you might generate new knowledge is fantastically rewarding, and to be able to share that to make greater widespread improvement for patient benefit is a noble and worthy cause, I think. Often getting started is really difficult and challenging. And stepping stone programs are absolutely vital, because as we know, the NIHR, ICA program and similar programs are highly competitive. So often it's just getting your first foot on the ladder towards research, training or clinical academia. So Jen is going to talk about this later, but I did want to mention sort of my full support for the Oxrain program that's been developed as part of this project, which is why we're talking about it today. I think it's a fantastic short program, but with part one being 2 online short courses and then a research placement that potentially ends in publication to improve early career researcher CVs is fantastic. So I look forward to hearing more about that. Okay, thanks very much.
Great, thank you so much, Terry, and thank you. I love it. People cannot be what they cannot see. That's a great analogy, and it's so true, isn't it? The more role models we have, and the more research gets integrated, the more I think the curiosity will come as well. So thank you for living this really at OUH. We will just move on to the next speaker, but I will remind you again at the end, we do have time for questions. So either keep them coming in the chat or have them ready for when we are at questions and brainstorming. So I'm delighted now to introduce Joanna Snowball. She's a Band 7 dietitian working with adults with cystic fibrosis in Oxford. She has recently been awarded an NIHR Oxford BRC Preparatory Research Fellowship, which is supervised by Dr. Koutoukidis, and she undertakes research into the emerging issue of overweight and obesity in people with cystic fibrosis. Joanna, the webinar is yours, so if you unmute yourself and go ahead.
Thank you very much for asking me to speak today. I'm just going to share some experiences that I've had over the last sort of 6 months, and I am very early in this journey, I think, and I just like to try and share some things that might help some other people who are trying to start off their research careers. So in December, I was lucky enough to be successful in my application for an Oxford BRC funded secondment for clinical researchers, which is a project that was run by Dr. Helen Worthall. And this involved a 5-month secondment period of 3 days a week. I maintained 1 day a week of clinical, working with 3 other NMAHP fellows. And the topic that we were researching was patient and clinician experiences of remote consultations, which was clearly very timely during the pandemic. And during this programme, we completed training in good clinical practice, informed consent. We did an introduction to qualitative interviewing, and then we planned, recruited, conducted and analysed semi-structured interviews with patients and clinicians. And during this, we were supervised we all had a mentor from Oxford Brookes University, and then we were also supported by Dr. Helen Worthall and members of her team. We also completed a narrative review during this time using a PRISMA protocol. And I think really by the end of 5 months, we're now at the point where we're writing up these papers and we're hoping to successfully get 3 publications from this project. This was a really big learning curve for me, and I went from really not knowing very much about the research process to being a lot more familiar with it by the end of 5 months. So it was a great stepping stone for me. So it then led on to what was I going to do next, and I was asked to talk about how I identified a research question. And for me, I have 14 years experience working with adults living with cystic fibrosis as a specialist dietitian. And over the last couple of years, there's been a paradigm shift in the nutritional care required. And this has been due to widespread availability of highly effective CFTR modulator treatments. And what this means for our patients is that their life expectancy is likely to be much better, and their day-to-day living is much improved. But coming with this has been an increasing prevalence of overweight and obesity, and this was not something that we ever used to see in cystic fibrosis, and the nutritional guidelines are not suitable for dealing with these types of issues. It's a complete lack of CF specific evidence, and there's definitely a need to identify novel, effective and acceptable strategies for weight management in this group. And I think really there's a really clear patient benefit here. We want to build some evidence for adapted nutritional guidelines, and really what I want is to be able to sit in clinic where I've got 2 or 3 patients every clinic who are struggling with weight gain that's been very unexpected, and we don't really know where to start. So for me, it's about sort of getting to the root of the problem and trying to find something that might help these patients. So I think in terms of where I could have taken my research ideas, there was a lot of options out there. And initially, when I was doing the BRC secondment, I thought about the NIHRP-CAF, the pre-doctoral programme. I realised quite quickly that I'd underestimated the application size quite dramatically, and that I wasn't going to be able to build an application for this year. So I kind of did some investigation into it and then decided to park it quite quickly. And the learning curve, I think, was about the importance of academic supervision. I hadn't really fully considered that initially, and also how important the training plan was and how that needed to be tailored to me and to my research ideas. I was then encouraged to consider the BRC preparatory fellowship application. So this was a local programme run by the Oxford BRC, which allows either part-time or part-time funding to do 2 days a week of research over a year. And I sort of thought this was a better fit for me because it's going to allow me to do a project which will hopefully lead to a publication and to build some ideas for my future doctoral studies. And I think, you know, the question is how I do this alongside clinical work, and I'm going to take this programme up to do 2 days a week and then maintain my 3 days a week clinical. So I'm still going to be integrated in both parts of my job, I think. So I was asked to talk about how I built this application. So that the key thing to begin with was identifying supervisors, and I think that was really where I needed a lot of help. So I was really lucky that I was giving an introduction to Professor Susan Jebb, who leads the diet and obesity theme at the BRC, and she was interested in my ideas and felt they did align with her research group. And then she suggested that I speak to Dr. Koutakidis, who himself is a research dietitian who hasn't worked in cystic fibrosis before, but has worked in these sorts of issues in other conditions. And we had a good chat about the research ideas, and he agreed to supervise me. The project that I'm going to try and undertake during the next year is a qualitative project, and this was largely a pragmatic choice because it fits with the experience that I've gained from doing my last secondment, and I'm going to look at how clinicians in adult CF care approach the management of patients with overweight and obesity. And hopefully during this time I'll have some time to build some future projects and to just gain some more experience in research and attend some research meetings with Professor Jebb's team. The next part of this puzzle, I think, was securing support from managers. And I've been incredibly lucky at OUH that I've had really, really good support from Terry Cordery and from my dietetic managers. And everybody has been really, really helpful and encouraging with this application. And I think that's made a massive difference. I haven't felt like I've had to jump over any hurdles to put this application together. It has probably made it easier that I don't require clinical cover to do this fellowship for a year, because I work part-time normally anyway. So for me, it's a case of increasing up to full-time hours for a year, and that has helped. Writing the application, it's quite a short form when I looked at it, and I thought, oh, this doesn't look like it'll be too bad. I quickly realised that it was a bit more in depth than I thought, and I had some really great support from my supervisor with shaping the application and just knowing how to write these things. I think when you haven't done it before, you need to know what to include and how to phrase things. I was asked about what background is needed to succeed when you're building a clinical academic career. I think for me, having a lot of experience in the clinical area has been really important. I'm really supportive, I think, of staff getting involved in research really early in their careers, but I think to develop your own research questions, you really need to be quite embedded in your clinical area. You need really good knowledge of the existing literature to understand what research has been done and where the gaps are. And I think what also is very important is experience of planning, audit and quality improvement projects, which I've been quite involved with in the last few years. And this gives you lots of transferable skills to be able to take to research. And it's a bit more achievable sometimes than doing research. I've had lots of support to attend national and international conferences at all stages of my career. And I think that really has been the thing that has sort of got me interested in research and allowed me to make connections with others working in the area. And now that's making things easier for building ideas going forwards. I think you also need to be self-motivated. You know, lots of building these ideas has been done in my own time. I think that's quite common in the world of research. It's not how it should be, but it is the reality. I have had really good support when I was on the secondment to have time to build those ideas, and that, I think, is why I've managed to build this application. In terms of barriers and facilitators to building the pathway I'm on at the moment, I think the barriers was having protected time to develop ideas. The only reason I've managed to get this project going, I think, is because I had a little bit of time available during my secondment to really sit back and think about my research ideas. I think the attitude of others, I've had nothing but support from my colleagues, but I think there's always that underlying guilt that you should be seeing patients, and should you be spending time developing these ideas? It takes a lot of time. Lack of role models, I think something Terry talked about earlier, and I would certainly echo that. There are people within the trust now. There's Dr. Jodie Eade and Dr. Owen Gustafsson who have NIHR awards, and they're certainly people I would look to for support. And as more people sort of build these careers, I think that would be very helpful. I think you also question your motivation about, how far do you want to get into this research world? You worry about coming out of clinical and concern about onward career plans, and hopefully there'll be more support for that in the future. So facilitators, I think, like Terry said earlier, again, the opportunity of secondment really opened the door for me, and without that, there was no way I would have been building a successful fellowship application. Mentorship, I've put in bold, because again, that's been really, really key. And just having those people that work in these areas, and just being able to ask all those slightly silly questions about how things work, and just being supported to find out things. Management support, again, as I said earlier, is very, very key. And also introductions to potential academic supervisors. It's impossible to build your research ideas without a good link to an academic institution, and I don't think I fully appreciated that before, so that's something that I would recommend that people look into if they do have ideas. So just to finish, these are my acknowledgements of all the people that have helped me during this sort of last 6 months. Thank you very much.
Thank you very much, Joanna. This is great, and it's quite inspiring to hear your story and how you have made your path so far. I'd be interested in the end to hear a bit more where you see yourself going as well. This is fantastic. Thank you. As the next speaker, it is my absolute pleasure to introduce Professor Karen Barker. Karen is a physiotherapist with a master's degree in ergonomics from Loughborough University and a PhD from Oxford Brookes University. Karen currently holds the post of Clinical Director for Trauma and Orthopaedics and Head of Therapy at the Nuffield Orthopaedic Centre. Alongside her clinical career in the NHS, Karen has maintained an active research interest. She is Professor of Physiotherapy with the Nuffield Department of Orthopaedics, Rheumatology and Musculoskeletal Sciences at Oxford University, and she's also a visiting professor at Brookes University. She has combined clinical and research throughout her career, and it's quite amazing, but her first project was as a junior physiotherapist over 35 years ago. So thank you very much for sharing your thoughts with us today, Karen.
Okay, thank you. Can I have the slides?
Jennifer, are you able to put the slides up?
Yes, it will probably just take a minute for them to load because it's quite a big file. So I don't know if you're able to get started while the slides load.
Okay, yeah, so I'm just going to cover a few areas, and probably because I've been around the block a little bit longer, I'm going to say some things which are slightly different to some of the earlier speakers. So, Terry said that unfunded research is unfinished research. I would say that I did my first research when I was what was charmingly known as a basic grade physiotherapist, so a band 5 in today's parlance. And basically I was just nosy and a bit curious, so I started asking some questions about some patients we were seeing, got together with a registrar, and we designed a very small scale research project, but we followed it through quite systematically, and that ended up being published in the BMJ. So I think there is a lot that you can do if you are curious and you're motivated and you work with other people. So, yes, it's great if you can get onto one of these NIHR programs, but there are other routes as well. Also. And so I think the key thing is that all research is down to a team, and every single person who is interested in research, they can start small. They can start by talking to people who are doing research and just doing a small part with them, rather than having to devise your own project, get your own funding, see it all through on your own. So as I said, my first project was tiny, but it was worthwhile, and it was looking at why we had all these patients who were coming in with unexplained stomach pain, and we looked at whether TENS, which is a sort of pain stimulating machine, would help them. We disabled half the machines and half worked, and we just compared the two, and that was done alongside a full-time clinical job, but was, you know, a good project, worthwhile, showed the benefit of TENS. Other projects which have changed practice have been really pragmatic. So my colleague Kathy Jenkins did one which was about teaching patients to kneel after knee replacement. And that purely came about because when people were filling out their outcome forms, there's a question on the standard outcome form for the Oxford Knee Score that says, how much trouble do you have kneeling? And they were all putting down, haven't tried it, was told not to, didn't know I could. So Kathy designed a very simple study which just taught half the patients at their 6-week review, we would make them kneel with us and show them that they could. Half we treated as normal. When we evaluated it 6 months and a year later, if you took 3 minutes to show somebody they could kneel, they carried on doing it. So very, very simple research study, written up, published, but changed practice quite a bit. Sometimes research is more along the lines of service improvement or quality improvement. So we've done quite a lot of work on accelerated pathways. We changed the pathway for day case knees at the knock, and rather than getting them bending their knees at the beginning, we kept the knees straight and then started bending at 5 days and evaluated that. And that involved a big team of the clinical physios all taking part in that project, and all then, you know, gaining from the benefit that had in terms of sort of profile for the department, but also for getting patients home much quicker. And then finally, we did an example of a big fully funded project. So the PROVE study was an HTA funded, couple of £1 million, 10 years of my life project. And that showed that it was perfectly safe to do manual therapy on patients who got an osteoporotic vertebral fracture, which is something that previously we wouldn't think was, you know, there were concerns about it. So next thing Anina asked me to talk about was how do you successfully integrate research into clinical practice? And, you know, it's as easy or as hard as you want to make it, I think. You've got to engage with lots of clinicians and lots of researchers. You've got to be very pragmatic about what your implementation plan is. You've got to look at, you know, what the reality of your working life is, what your clinical resources are, and then adapt your research to fit the resources that are available. If you're aspiring to do something from the best research you've ever read published, which gave 142 sessions, you're not going to be able to do it. So be practical, be pragmatic, talk to a lot of people, and accept the need that you are going to be stepping in and out of your clinical role and your research role. They're not going to run absolutely in parallel seamlessly throughout your time. So how does a research involvement benefit your career? I think it gives you opportunities to work with lots of other teams outside of your immediate clinical team. So you get to, you know, talk to a much broader range of multidisciplinary people. You learn a lot about different ways of thinking and different ways of working. I think it raises your profile. So you know, if you've presented at showcase events, if you've published something, then it adds to your CV, it adds to your profile, it makes it easier to move on to the next stage, perhaps. I think it makes your career interesting and varied. You know, if I'd stayed just doing pure clinical work for 30 years, then, you know, that fits a lot of people, but I've got a low boredom threshold. I think by doing research, it's made my career much more interesting and much more varied. And I think it takes you outside of your own department, your own directorate, and exposes you to the wider trust and the wider academic world. How did it benefit the trust? Well, in some ways, I don't know, I'm the person to answer that, but it definitely increases the profile for the department, both internally and externally, for the trust. When we've looked at staff that we've recruited into the physio department at the Nufford Orthopaedic Centre, then when we're interviewing them, over half of them mention the physio research unit. And when we ask them a question about a recent research paper they've read that they thought was influential, then a lot of them are able to cite our own research. So I think it has definitely helped recruitment. I think it helps retention because I think it widens the opportunities for the staff who are working in clinical roles. I think it gives supervision of other AHPs who are undertaking either their master's degrees or who are wanting to go on to a further higher degree. I think having people who are working alongside you who have got those qualifications opens up a lot of informal routes for supervision. I think it gives mentorship for other people, both those people who might want to do research, but also those who are wondering about it and just want a discussion about, is this for me or is it not? So I think it adds role models for the trust, and it's also brought in a lot of research grant income, which obviously supports the infrastructure for the trust. And my final bit is sort of top tips. And I think that the main thing is that you need to be flexible. You need to accept that there are times when you will be doing research activity and it will be, well funded and you'll be immersed in that. There are times always when you've been funded for a year, 6 months, 3 years, and that funding has come up and the funding doesn't seamlessly go from one to the next to the next. So you have to be prepared to step in and out of clinical and step in and out of research. And sometimes you will be doing 50-50, sometimes it'll be 80-20 in one bit. Sometimes you may have no funded research, and so you're back to working full-time clinical and developing your next idea. I think small scale research is often far more impactful than some of the very large research questions, so it doesn't have to be big to be worthwhile. Small questions are just as important. And I think great research can come from quality improvement and service development projects. It doesn't all have to come from a formal written research grant application and the funding that goes with it. So I think that if you're interested, you're curious, and you're prepared to put the extra effort in, then some involvement in research is open to every single person who works within the trust and should be encouraged. So thank you.
Fantastic. Thank you so much, Karen. And just a great example of, where it can lead to when you incorporate clinical research directly in clinical practice. I'm quite fascinated by the knee studies. That's such a great example. Thank you. Now, we'll get to Jennifer. Last but not least, please welcome Dr. Jennifer Carter. She's an Associate Course Director and Senior Research Fellow for the Nuffield Department of Population Health at the University of Oxford. She was also awarded the title of Senior Fellow of the Higher Education Academy for her leadership in teaching excellence. She's here today to introduce a range of training opportunities that are open to NMAHPs interested in pursuing a clinical academic pathway. But first and foremost, one of the new programs that will be open to you. Welcome, Jennifer.
Great, thanks, Anina. So I'm going to end today's webinar before we open up for questions, looking at the training pathways that would be available for NMAHPs to access clinical academic careers. And hopefully some of the topics that have been presented today have sort of piqued your interest in thinking about getting involved with research, but maybe you don't have any experience, so you don't really know where to start. So my talk is just going to show you this pathway, thinking at the very beginning, say you have absolutely no experience whatsoever, what do you do? Well, we'll look briefly at some courses, and then I'm going to focus mainly on where the Oxwayne program might fit in this sort of overall trajectory that would lead you to applying for sort of more competitive internships and hopefully eventually very competitive pre-doctoral and doctoral fellowships, which will really set you on sort of a funded clinical academic career pathway. So I'm not going to present all the courses. If anyone's even done a search on Google, there's sort of an innumerable amount of courses that you could take that might help you with the beginning steps of a research career. But I just thought I'd highlight a few of the main providers that have some of these introductory courses that you might be interested in if you don't have any experience yet. So you could look at the University of Oxford, look at some introductory courses on medical research skills, or maybe looking at what research planning is or research design is. Okay, if you haven't done any academic writing for a while, there's a lot of courses from Equator that might help you with your writing skills. And you may have noticed several of the talks have highlighted understanding the literature base, or understanding what research has already been conducted on an idea or a research question you might have. Well, if you don't have any experience with that, then don't worry, because there's the healthcare library, and they have lots of introductory courses for how you might run a literature search, how you might sort of make sense of the results that you would be getting from a literature search. So that's quite a nice place to start. The NIHR has a lot of courses available on their Learn sort of app that they have. They have a nice course at the moment called Improving Healthcare Through Clinical Research, which kind of shows you the whole scientific process of what we would call from bench to bedside. So you have a bit of a research question. How might you go about testing it? And then how might you go about disseminating the results and implementing them into changes into healthcare? And that's all free and available online. If you have a research question that you might want to develop in a bit more detail, then there is the Research Design Service, which has a lot of development workshops, a lot of one-on-one tutoring that can really help you develop a research question into something that would be with a research project. And everything that I've presented here is presented on the NIHR BRC Oxford website, which has a really good selection of training and educational resources all in one place for you to find the courses I've listed here and more courses that will help start you on your research journey. Now, what I'm going to focus a bit more on during my talk right now is this unveiling of the new Oxford Research Introduction program that we've been developing with Terry as part of our BRC project. And essentially what the OxRain program is 2 short courses and an optional short research placement. They're all part-time, they're all online. They're really designed to sort of fit around the working life for NMAHPs that have little or no research experience. So the first part of the Oxford program is an introduction to epidemiology. This is a 1-week course. It's about 3 hours of contact time a day. And essentially epidemiology is the science underpinning public health. Okay, it centers around the study and of the patterns and the effects of diverse health problems in the population. And it really provides the foundation of research methods underlying modern evidence-based medicine. The second part of the OxRain program is a statistics course, practical statistics for health research using R. And this is part-time, again, about 3 hours of contact time a day over 2 weeks. And this is really aimed at participants with little or no prior experience with statistics. So if I said the word statistics and your blood pressure increased a little bit, you're like, oh gosh, don't worry. We've been teaching this course for years for an incredibly diverse student background with people with no statistics experience. And we know that we can take you from the basics and sort of deliver you to a place where you can actually produce publication appropriate real world health related research. And that's basically what we aim to do in this 2 weeks. And we do it on the freely available package R, which you could download on your home computer. So that's the second part of the OxRain program. And then the third part is a sort of optional short part-time research placement. And this would be done online with supervisors from OUH and supervisors from the University of Oxford. And the part 3 of this program is really for you to apply your skills from the short courses to real world data. And we've designed this program. It's been inspired by the training that the medical doctors go through as they train for clinical academic careers. So we know it's quite a good pathway for getting people onto the research pathway. And, some of the research that's been presented already today has shown you a really nice picture of the benefit of qualitative health research with interviews. And this often links up very nicely with quantitative research, which is what we're training you here. And quantitative research might be more along the lines of something like Karen presented about the knee, kneeling after knee replacement. They had to look at the data, they had to look at the outcome forms and see that people were not kneeling after they had their knee replacement. Well, that comes from the quantitative data. You look at the data in the hospital, you identify a question, maybe, some types of patients have worse outcomes than others. Well, what is it about this type of patient that tends to have a worse outcome? You identify with that with the quantitative data, and then you could go on and apply for an internship and get more training to look at that more in depth with some qualitative research. All right, so at the end of this third part of the quantitative research placement, ultimately we want to give you a research deliverable that you could put on your CV, such as a presentation at a conference or submitting to a peer-reviewed journal. And we really want to help you gain the skills to harness the power of the big data for the benefit of patients. I mean, you probably know, how much data are you putting into computers? How much digital data are you generating and working with in the hospital every day? Well, if you have the ability to look at all of that hospital data and find out sort of answers to research questions, that's going to provide a huge potential for your career going forward. So the Oxbrain program, you can apply for parts 1 to 3 in a modular fashion. You don't have to do all parts of the course. You can just do parts 1 or part 2 if that's what suits where you are in your career development. Pre-registration is open now. It's on our website, or you can just Google Oxbrain. We should be one of the first results that pops up. I would highly recommend that you pre-register. And what that means is you sort of put your email on the list. And when formal registration opens up in December, I will let you know first before formal registration opens up. And the reason I say this is that when we've opened up these courses in the past, for example, the statistics course was fully booked about 5 hours after we opened registration last time we ran it. So they get booked up really quickly, but we really want to ring fence the Oxbrain program for NMAHPs at OUH. So if you pre-register now, you will have the first dibs on signing up to this program before we open it more widely across the university. Okay? And NIH BRC Oxford has provided funding for 5 NMAHPs to attend the short courses, but we can take up to 16 if you bring other funding with you. So what that means is that we definitely have place for 5 people. There will be a very, very small application process, not onerous at all. I'm talking about like sort of 3 or 4 questions, which you can apply for one of the 5 funded places. But if you bring other funding, then we can take up to 16. In terms of other funding, the NIH BRC has research training bursaries. These aren't open at the moment, but I hope that they will be open later this year. But at the moment, the Oxford Academic Health Partners Charity Awards, they are open with a closing date on the 15th of July, which would provide more than enough funding for you to do the Oxbrain program if this was something that you wanted to do. And then I'm just going to finish up my talk with just coming back to this whole research training trajectory that you could sit on. After you do the Oxbrain program, or maybe do some of the other courses, and you find that research really is for you and you want to develop more in it, you can start applying for some internships, which are sort of more part-time secondments from your clinical training to get more in-depth training in research. So there's one available for nurses right now, which is a closing date that's coming soon. Then there's the ICAP program, which is considered sort of a pre-master's clinical research taster, which occurs over sort of 6 to 9 months. Or there's also the applied research collaboration, which is another sort of 12-month program. And the applications for these internships are due in June. So if this is something that you're interested in, you've kind of got the next year to sort of do the very introductory courses to sort of prepare yourself and get yourself situated to apply for internships next year. Ultimately coming back to this aim that maybe after some internships you'd be very competitive to apply for pre-doctoral fellowships at the master levels or doctoral PhD fellowships. Okay, so just in summary, what we've spoken about today is here's a potential pathway that you could take if you're interested in it. You could take some online courses at any time, an introduction to research. You could apply for our Oxbrain program. Applications go in December. You could take this over next April, and then from that you could be in a good position to apply for some competitive internships that might come in June. Those would run over the autumn, and then hopefully you would be in a good place to start applying for some of the more competitive pre-doctoral and doctoral fellowships. So if there's any questions, we got some questions now at the end of this webinar. Anything about the Oxrain program, you can ask me now or you can email me. If you had questions about some of the other aspects of this research trajectory, particularly about the internships and fellowships, I would suggest you contact Karen at the Oxford BRC, and she would be a great source of knowledge to sort of help you on your pathway. So I'll go ahead and
Thank you so much, Jennifer, for introducing this new program. I wish this was available when I first started doing research, because statistics can be a bit daunting, isn't it, in the very beginning? And if you get that opportunity to learn in a kind of safe space, even using data from your own hospital, that's quite exciting, I think. So we are open for questions, so put them in the chat or unmute yourself. But I will start with the first question that has been put up by Sally Beer, who is working in, if I remember correctly, CRN trauma team. And Sally asks for Jennifer whether it's possible to sign up for the whole program, or can the courses be done separately? And you already mentioned you can only do the first one, etc. But could you in fact also just do the internship or the placement, or would you have to do the statistics course first?
Yeah, so you can definitely apply for just one or two of the courses, and again, it's sort of setting you up for what you need for where you are in your research career. I hadn't thought about doing the placement by itself separately, but I think that would be fine. I think as long as you've had some training in working with data before, then there's no need for you to go through another statistics course. You could go ahead and do the placement. Obviously, you just have to sort of have a chat to make sure that would be okay. And then yeah, it'd be fine for you to just do the placement if that's where you're at and you wanted to have that sort of research taster. Then that would be more than happy to help facilitate that.
Great. I was also wondering about the backfill problem that sometimes can be a barrier for NMAHPs to enter clinical academic careers. I was wondering whether Helen or Terry could maybe quickly comment on that, options for backfill or how something like that could be organized.
If I go first, Anina.
Perfect, thank you.
So at the moment, internships are being funded predominantly, any backfill, predominantly by the BRC, but it is a strategic direction of the OUH to support NMAHP research pathways. And so only this morning I had a meeting with Sam Foster, our CNO for nursing and midwifery and AHPs, and it is part of our objectives in the next year to work through how we fund a pathway in all professions throughout the trust.
Great, thank you so much. Terry, was there something from your side, from the AHP side, or I guess this overlaps quite a lot with Helen's work as well?
It's a difficult area, isn't it? Because we want research or research training to be funded so that we can replace the person, so that the load on the team that they're leaving temporarily isn't increased. But we know it's difficult to get people into short-term roles, and I think it carries a risk, but I guess it does come down to sort of leadership and management being able to say, are we weighing up the cost and benefit, are we able to release this person and try and get some backfill, knowing that there will be possibly greater benefits for that person to come back with a bit of research training and to be able to positively influence the team that they work in. Yeah, challenging area.
That's great. So that really means, Terry, if I interpret correctly, AHPs who want to go down that road really should talk to you potentially and see whether the questions they have might be of interest to the trust and the kind of priority areas that you might have.
Yeah, of course. And sometimes we can't facilitate everybody going off and doing research, but we certainly try and do that where we can.
Fantastic. Thank you so much. Does somebody else have a question right now? Otherwise, I actually have another question as well. And my question is a bit, when we think about NMAHPs and our clinical academic career pathways, we are really lagging quite behind our medical colleagues in our clinical academic career pathways. And I would be interested to know, maybe from Karen, whether you think whether we are just not curious enough as NMAHPs or not courageous enough, or what is the reason that we haven't got it sorted as yet?
So I think in the junior days, you know, the medics are very motivated to do research, partly because, you know, it is an expectation that when you're going for a consultant post that you will be asked questions about your clinical audit activity, but you will also be asked questions about what research you have done. And so, you know, they are all very motivated to boost their CVs, to get some publications in. You know, I think it's probably fair to say a number of them will never do any research at all once they've got a consultant post, but others genuinely are interested as clinical academics. Obviously, there is a better structure in terms of funded clinical academic posts and being able to go out of programme to do research. But, you know, I've managed the trauma and orthopaedic medical staff for the last 10 years, and they work indescribably hard. And I would say that most of their research, they're not doing it in the 40 hours that they are paid for by the trust. They are very good at networking. They are hardworking. They do a lot. And, you know, I think it's not a competition. We should also look at how we work with them. You know, every project has room for lots of people on it. So as AHPs, we should be working alongside our medical colleagues if there's a question that's important to both of us, but with a caveat that we make sure we get our fair share of the credit and our fair share of the output. We don't do a lot of the work and not get the benefit. But they're a bit further ahead of us, but I think they are also very, very motivated, because you don't get up the career ladder as a medic without having done some research.
Great, thank you so much. I think you're absolutely right, isn't it? We shouldn't shy away from collaborating outside the NMAHP community, absolutely. And there's so much happening in Oxford itself that it is possible, but it can be a bit daunting, I understand, right? Sometimes finding your foot and as you correctly say, Karen, also making sure you're being recognized for what you are, etc. So that's really good. I was wondering, Joanna, as well, you know, I mean, it sounds like you really have found your way through the jungle of how to kind of enter a clinical academic career. Do you mind letting us know where you actually do see yourself, say, 10 years down the road from here? Do you have a clear plan, or is that still kind of, you know, in the making, basically?
Yeah, I think it is still in the making. As I say, I think ever since I was at university and qualified, I've always been really interested in trying to do some research. And I think some people just sort of have that kind of mindset, don't they? And I think I've always been quite curious and wanting to understand, well, why isn't there any evidence for this, and why do we do things like this? And I think it's difficult to know kind of how I'll build from here. I mean, I think the ultimate aim would be to do a PhD. I think the routes to doing that are many, and I would be keen to continue working clinically. I do see myself as wanting to develop as a clinical academic. I don't think I would want to enter academia full time. You know, I really like working clinically, and I think it really benefits my patients to be able to combine the two things. But I don't have a particular time scale to it. I think I will see how opportunities come up. I think that's what I've learned the last 6 months. I've had 2 opportunities in quite quick succession, and I've had to, you know, I've been provided with those opportunities. I've had to put the work in to make them happen. But I think, yeah, I just continue seeing what's out there. And I think what's really, really helpful is just talking to other people. I've got quite good connections with people from around the country that work in my specialty, and there's quite a lot of dietitians specifically who are doing doctoral programs. So I think it's just really finding out how other people build these careers and just thinking if that could work for me.
Fantastic. That is really inspiring, as I said. So it's great to see that you're well on your way. I would like to, because we have to wrap it up, I'm sure lots of you will have to get back to clinics, but I would like to thank you very much for attending. First of all, we will make the slides available to you, and we will let you know via email, subscription email, how this will be done. The recording will also be available if you want to look back on the different opportunities available to you. Importantly, we also have a quick few questions for you, which you can find in the top bar. There is this little kind of Vivox, it's like a speech bubble. If you click on that speech bubble, it should open a little new field, and within that new field there's a little clipboard, and if you click on the clipboard it will take you to some questions. And we would be quite grateful if you wouldn't mind filling in these questions, even if you might have done the survey before. Let us know maybe something has changed for you or not. But yeah, if you could go to the speech bubble, Vivox speech bubble on top of the Teams bar, and then to the clipboard to answer some of the questions. Last but not least, I really would like to thank all the speakers today for what I think is quite an inspiring, different inspiring perspectives, really, all the way from entering the clinical academic career, the view of managers, from Caudrey's side, Helen's side, in how she massively helps us build these clinical academic career pathways here in Oxford. Karen with the hindsight of the clinical academic career pathway, and then a massive thank you to Jennifer as well. I think this is just a very exciting opportunity, as I mentioned, that I wish I had available to me when I was entering the career. And I do hope that some of you might be interested, and don't feel shy contacting Jennifer directly, or you can also contact me if you have any questions. So unless there is any other questions, I will wrap it up here. We will leave the meeting going a bit so that you can fill in the questions, and we hope to see you in person the next time. Thank you very much.